Christine Sakuda, I'm the Executive Director of the Hawaii Health Information Exchange, and I'm glad you're joining us today for the Health IT session. We're running a little bit behind schedule, so we were told that we have to end at 12 p.m. sharp. So we're going to go ahead and get started. We have 3 presentations today, and I will introduce our speakers. Each one gets about 10 minutes, so I'd like to kindly ask that you hold your questions until the very end. We do want you to ask questions, and we do have a mic ready for you, so please be patient with us as we present to you. The health information technology is the most indispensable tool to enable healthcare transformation. Effectively utilizing health IT is the key to quality improvement, cost management, and transparency. Without real-time, reliable information, our healthcare system cannot move toward accountability and integration. So this session will address these, and you'll find out how each of these stakeholders are using health IT, accelerating the adoption of health IT, and using it very effectively. Our first speaker is Mark Linscott. Mark has over 20 years of experience in healthcare. He works for Kaiser as the director of HealthConnect. He provides leadership, business, and information technology acumen and management for the region's electronic health record system. So you have the bios in your presentation. In the interest of time, I'm going to skip over them. And thank you, Mark. Please join me in welcoming Mark.
Thanks, Christine.
Thank you.
And thank you for that warm welcome and aloha. As the governor spoke this morning, I am also a Kaiser Permanente member of over 20 years. So we want to kind of demonstrate, and hopefully everyone can hear me. Is that better? Demonstrate, the model that Kaiser Permanente chose quite a bit of time ago, and I think it's appropriate because I think it's going to share some of the transitions of healthcare in Hawaii that you can leverage in terms of getting the accountable care organizations, networking with your providers, and also incorporating the public-private partnership that I think the governor and all of us really want to happen to improve the health of Hawaii's people. So I'm going to start in, who are we? Kaiser Permanente Hawaii is the health plan of choice for one of our 6 residents here. We employ approximately 5,000 employees. That includes our 410 physicians. We are one of the top largest employer in the state of Hawaii, and Kaiser Permanente Hawaii serves approximately 224,000 plus members throughout all the islands. On Oahu, we have a licensed 285-bed hospital, and that provides adult and maternal care services. So one of the challenges from our perspective was, well, how do we enable this transformation of change? And going from an integrated healthcare system like Kaiser, which AKA accountable care organizations, that's really what Kaiser Permanente started, as Governor talked about, 5 decades ago. And so one of the ways that we wanted to enable that was through technology. And so our leaders and our board of directors thought long and hard of how are we going to get the platform to standardize IT systems across the nation. And that's really what we embarked upon in about 2003, actually before that, but we've had some stumbling and learnings along the way, and finalized what we actually call HealthConnect, which is our electronic health record. It is rebranded under Epic Systems, which is out of Madison, Wisconsin. And a lot of it was around, well, could we really do that? Can you really get all the information under one house and share that across the continuum and really help improve the lives of our members while customizing what they need at any given time? HealthConnect was the catalyst and continues to be that way for transforming care delivery. Moreover, it is not just about the technology, it really is about the people. And so we wanted to improve the health of our members, and that enabled how our care delivery processes work more efficiently. And most importantly, here in Hawaii. So it's not just about our Kaiser members, it's about all the folks in Hawaii and can leverage the technology that we have available to them. So why did we invest so heavily in HealthConnect? And this was billions with a B that our national program took on to put the infrastructure in across our 8 regions. And so one of our promises and our mission is really affordable, quality healthcare. And so to achieve that, we had to look at systems differently and processes, change management, how do we engage the patient in their care, improve those outcomes that folks are looking for, as well as behavioral changes in the personal care of that person. So our promise to our members was really the benchmark of why we invested heavily into the application, because we felt strongly about our mission to improve quality, to reduce costs where appropriate, and improve the overall well-being of our members, and also make it easier for our healthcare workforce, physicians, nurses, technicians, to care for our member at any time. So the importance of the health information is just an enabler. It's a tool. So to do those, I call them BHAGs, or big, hairy, audacious goals that we have to do, we needed a system to do that. And so KP HealthConnect for Kaiser is that sophisticated information system. And it's a managed care delivery designed to enhance the quality of our patient care. It integrates the electronic health records. So you remember those paper charts we used to deliver from facility to facility? Well, now we have it at all our facilities at any time at the fingertips of our clinician. And it's not that long ago where we were trucking around pieces of paper to say, how am I integrating? Did you see your dietitian? Am I going to go see the cardiologist to take care of the member? And moving those charts back and forth. And guess what? We didn't always do a good job of making sure the chart got to the physician when the patient showed up. And so now we have the system to actually do that. And along with that, we've incorporated the appointments, the registration, admission documentation, of course, the billing, so that we could sustain ourselves. The system also links across the nation. So we have what we call our Kaiser program, and so we share our medical records. So if you get sick in Baldwin Park in Southern Cal when you're in Disneyland, you can get your Kaiser Hawaii medical chart there by your physicians. The other pieces that we have is the neighbor islands. Because we're so diverse across the islands, how do we get that information between the islands? And so HealthConnect provided us that way to do that, and then care for the members in their communities rather than having them always fly over to Moanalua Medical Center, which actually improved our costs there. The other piece that it does is connects to the other world, which is some of our panelists here with the Health Information Exchange. How do we connect information outside of just Kaiser Permanente to share public health data, to exchange information for Kapiolani or Queens Medical Center, where we have admissions happening and people going and repatriating to Kaiser Permanente. We want to make sure that the information is seamless, as well as the care to that member is seamless. As a result of implementing KP HealthConnect, we realized tangible benefits. One of those, most notably, was we saw an 18% reduction in our doctor office visits. Well, you can say, well, what happened? Well, we actually gave the tools to our clinicians to be able to make the right decisions so we could respond and resolve their treatment at that time rather than having to bring them in. It's kind of what we heard about from this morning's session around length of stay and coming back for things that we should have taken care of the first time. And so we did see those reductions. The other thing is it helped improve medical errors in our hospital stays when we implemented CPOE at Moanalua Medical Center. I mean, sometimes I don't know if you've seen your doctor write on a prescription pad what that medication, and I don't think I could spell or even say the words of what he was going to offer me as a treatment. So now we can. You can see it. It's in print, and everyone knows what he intended or she intended to do. The impact and benefits have been felt throughout KP, and as a new standard of healthcare industry as a whole, building health conscious and increasing patient safety. So we've done that through skip measures in our hospital, which from the member's perspective may not care so much, but the quality has improved as a result of the electronic health record. Transforming care at Kaiser, we've been doing it since 2004, and actually prior to that, we had some learnings with some other systems, notably IBM, and we've really learned from that. So you kind of stumble your way and you kind of improve as you get better at how do I change practices, how do I engage my physician partners, my nurses to do their advice calls differently than they have in the past. And then overall, how do you engage the patient, into their care? So can I go online and see my last lab results? We also release our diagnostic results from the radiologist to the patients. Well, what does that mean to the member? Well, they're not waiting, and they see it just as quickly as the physicians do in terms of what their results and outcomes are. So if I'm a cancer patient and I'm at a support group tomorrow night, I know what my white blood count cells are and how I'm doing so that I can, get some support from my group and improve my health. KP HealthConnect quickly became a foundation of how we deliver care to our members. So it is the focus, but it isn't what we do at Kaiser Permanente. It enables our care providers to improve our patients. And for all regions, national teams involved in implementing the systems, and there were tens of thousands users, as well as user go-lives at each of our facilities across the program. It felt like an endless journey, and it really was. But upon reflection, it really has become remarkable to see how far we've come. We've made that change from trucking around those patient charts to what we need to do in bringing that care to our physicians and care providers. So I'm not going to read through all these benefits, but there are several, which is most notably the high quality. By bringing in a health information system, you actually improve the outcomes of our patients. We've enabled our care delivery and integrated practice guidelines. So what do you mean by that, Mark? Well, what we've done is use the tools that HealthConnect or Epic provides to help in the documentation. So if I'm a diabetic patient who has a hemoglobin A1C greater than 7, I can do that. We also have personal care, convenient care, and affordable care. We've achieved various benefits in terms of the 5-star rating, the NCQA Joint Commission, and the PCMH level 3. And we haven't been able to do that only because of the enablement of KP HealthConnect. One of the opportunities is our outreach through kp.org, and that's where the innovation is. How do we get weights and blood pressure checks into the system so that can go to your dietitian or to your care provider and move it forward? And people talk about the computer. Everyone has some type of cell phone now. That's really going to be where the action is. So how do we get the information to our members? And KP HealthConnect brings that to them. So I'm a little out of time. I'm happy to answer questions. Please write them down, and I'll turn it back over to Christine. Thank you.
Thank you, Mark. Our next speaker is Dr. Rorie Magnussen. Dr. Magnussen is the Associate Dean of Clinical Affairs at the John A. Burns School of Medicine, who is responsible for planning and development of clinical activities through the school. Please join me in welcoming Dr. Magnussen.
You notice that she did that for me. She knows I'm the doctor in the group. It's really appropriate, I think, today for me to be surrounded by CIOs on the table here, because sometimes that's how physicians feel these days in terms of what's going on with healthcare and electronic health record. Two very accomplished CIOs here running nationally recognized systems. We have a lot of assets here in Hawaii to really help drive this process. But we got to remember what's going on in the front lines and what the physicians and the patients are experiencing. And so I want to kind of put that into context. My role today is to try to raise some questions about what are the physicians experiencing and what do we need to do to get them on board with this and make sure that they're effectively engaged in the process of using this health IT to its best advantage. So a couple things. It was a great presentation today on the history of healthcare transformation nationally over the course of the decades. I would describe that as the 100,000-foot view. Beth and Ginny Pressler have been working at the state level to really put together a number of really basic strategies for us as a state of Hawaii to put together and try to transform the healthcare that we're doing here. That's the 50,000-foot view. I know many of you are working in your organizations and trying to create a really strong system of care within your organization to try to improve communication and the patient experience. So that's the 25,000-foot view. I'm the ground level view. I'm going to describe to you what happens at the ground level a little bit, or what the folks on the front lines are feeling and what would need to happen for them to be engaged in this process. And the value of doing that is I think that the fundamental unit of what we do is an interaction between a patient and a provider. And it happens in the clinic or it happens in the operating room. And the experience that happens during that event is what will determine the patient's perception and actually the provider's perception about the quality of care that's being provided. So it's important when we start thinking about all the systems of values of having an electronic health record and the IT infrastructure that we're describing, that we make sure that we implement it in a way that it doesn't devalue what's going on in that clinic environment, because that will determine our success in the long run. So this is a picture of a physician. Yeah, I'll let you determine whether you think he is happy or not happy. But this is a Physicians Foundation survey. They send this survey to all the practicing physicians in the United States, and they got about a 13% response rate, which gives you a little indication of the level of engagement, right? And a number of statistics came out of this that I just want to share with you about, just in general, where physicians' heads are at right now. So 77% of the folks who responded to this survey said they were very pessimistic, somewhat or very pessimistic, about the future of the medical profession. Okay? 84% agreed the profession was on the decline. And 58% they would not recommend becoming a physician to their children, which is kind of the gold standard, right? Now, 1/3 said if they had to do it again, they would not choose to be physicians. So that's really sobering information, right? The folks that we're trying to engage in this process and to convince that we need to really revamp the way we do things are in a state of mind right now that is not all that enthusiastic. There was one other element in that survey that I thought was really an interesting and telling fact, which is a little extraneous, but I'll get back to it in a minute. 22% of their time is spent on paperwork. And interestingly, if you've looked at the national workforce projections, we're projected to be about 160,000 physicians short in the year 2020. And it turns out if you translate that 22% of paperwork into FTE, it's just about that same number. So for my challenge to all of you is let's reduce that paperwork and let's streamline what's going on with physicians administratively, and then that'll help us address their level of engagement and also the shortage of physicians that we're going to see. So why are they disillusioned? A lot of it just has to do with managing the amount of change that they're experiencing, right? So think of the things that are changing. We're changing how physicians are organized from small groups to larger groups to ACOs. We're talking about changing how they're evaluated. A lot of the information we're talking about collecting is about determining whether they did a good job or not, right? We're talking about changing how they're paid. So while we're a state that's moving ahead with the patient-centered medical home, I can tell you in the practice, the faculty practice, we have to know how to do all the billing and collecting, and now we have a second revenue cycle where we have to collect quality data and submit it so we can get paid the rest of what we get paid for that visit. And that makes it twice as hard to get paid for what we do. It's changing how we interact with patients. There's a computer in the room, and people are very concerned about how that interaction affects what we do. It's increasing, there are ever-increasing administrative requirements. The role of the physician is changing. We really need to be a team member now, maybe not the star on the team even, in many situations. So we have to learn to behave differently. We have to learn to integrate differently and be part of a system and a little less independent, which for some of us is pretty difficult, just so you know. And then that's the loss of control. So that's what they're experiencing. Now this is a slide, Kelly Withy's in the room somewhere here. She's at the School of Medicine studying what we have in terms of workforce here in the state. We've surveyed that in 2010 and again in 2012. This is an older slide that showed that we had predicted that we were about 600 doctors short in the state when we initiated the study, and that with the growth of folks in the baby boom generation and the demand for health care and the growth of the population, we'll probably be 1,500 doctors short or 1,600 doctors short in the year 2020. So it's very important that we address the issues about implementing the electronic health record and is sensitive to this process, right? So because a couple of things. If we implement it in such a way that we drive senior physicians or older physicians to retirement, it's going to aggravate this situation. If we do it in a way that it slows them down so they see fewer patients, it's going to aggravate the situation. On the flip side, if we do it well and make it very efficient, we can improve this situation with what we're doing. So how do we engage physicians in utilizing HIT in their practice or health center? And what support do they need to make this transition? Well, it turns out that 10 years ago, that might have been one answer to that question. But now 10 years after implementation and some of the really nice systems that you're going to see up here today, there are physicians that are scattered along a continuum of involvement in the health IT situation right now. So we have physicians in the state who are still on paper, and we have physicians in the state that are already functioning in very well integrated systems that are up and running and are now really focused on how to really do continuous quality improvement within those systems. And they have different needs, right? And we have to collectively make sure that we meet the needs of all of those elements to get everybody on board and move things along. So here's a slide that's from the Hawaii HIE. It's part of our assessment in the, where we are in the state. So if you look at office-based practices in the state, what percentage of them are on an electronic health record? It looks like it's about 40%. Now keep in mind, that's not all the hospitalists and the folks in systems like Kaiser and HPH, but those folks that are in solo practices out there, and this state has a lot of people in solo practice compared to other states, their penetration is not yet at 50% on the electronic health record. So there's a lot of work to do at the very basic level. So we need a different approach to the three different levels. And so I broke this out into three levels. One is no EHR. What do those doctors need in terms of help or support to bring them along? They've implemented a solo EHR, and they now need to go to the next level. And then finally, they're in a system that's already well integrated and functioning. What do they need from their system to continue to really optimize the use of health IT? And so this is group one. And if you survey folks who have not yet entered into an electronic health record and ask them, what are your concerns about doing this? Why have you held back in getting involved in an EHR? Expense really bubbles to the top. They're all worried about the cost. These tend to be solo practices, small group practices. They don't have a CIO. They don't have a lot of resource or technical expertise. And so those two things, it's really complicated and it's pretty expensive, are the things that they bring up. Finally, they may or may not be comfortable with the use of a computer, and they are worried about the impact on patient care. So what does this group need? It needs expert support. It needs help in vendor selection and in choosing the right software because they really don't know what to buy. Okay? They need help in funding it, and that was the whole purpose of meaningful use, right? To try to get people to use the computer and then reimburse them for bringing it up. They need help and maybe the extension of the safe harbor so hospitals can help them come up on systems without being penalized for creating some kind of inappropriate relationship of some kind. And they need help with the workflow design. They really, a lot of times these things get implemented in the office and they're basically just replacing the paper record, and they haven't really optimized the use of the electronic health record. And so they need help with that. One way that we've done that in the state of Hawaii is that the HIE applied for and received a $5 or $6 million federal grant, and we created the Hawaii Pacific ReSee. This is a group of folks who are going out to the offices, identifying what they need, helping them get set up, and helping them meet meaningful use. The penetration so far is about 659 physicians have been helped with this process. Not quite yet up to meaningful use. Part of that is the Medicaid process still is now getting underway. But a lot of folks have already been brought up on this. Just as an FYI, the grant runs out next year. So we'll need to figure out how we're going to bring the rest of folks up on electronic health records. These are the things that they can do for them. If you have interest in this, talk to Christine about this afterwards. But the idea is to help physicians who are on paper get on some kind of system and provide the need that they need at this time. So what does the second group need? They're up and running on a standalone electronic health record. They're still worried about expense, but now they're worried about connectivity. How do I connect this to the labs? How do I connect this to the radiology suite? How do I connect this to the hospital I work in? And they're worried about security because now they got to worry about HIPAA. They've got electronic health records, and they're worried about how that connectivity affects their security in their system. They're also worried about productivity. In a survey of folks who have already established and met meaningful use criteria, they still say it slows them down in their patient interactions. And that's something that we need to fix. It needs to augment that process. And they're worried about all the different quality metrics that are now out there and how are they going to collect those in their particular electronic health record. So what do they need? They need expert support again. They need secure links. They need to document their meaningful use. And they need to probably now revisit their workflow design because all the things they didn't think of while they were implementing the electronic health record, they now know how it works, they have better ideas, and they probably need to go back and optimize it. Right? So the Hawaii HIE is really something that I wanted to highlight today because, again, another federal grant has helped us establish the process, and we're well on our way to connecting the dots. And the HIE, the purpose of that is to create the connections, the secure connections between physicians' office, hospitals, labs, pharmacies, and all the health providers out there where health information might be exchanged so that we can create a system rather than 30 different standalone electronic health records out there in the community. Something to think about. We're on year one of a 3-year plan to make these connections. So hopefully 3 or 4 years from now, we'll be able to say that not only does the doctor have an electronic health record, but it connects to the things that it needs to connect to. Last but not least, there's the integrated group, or the people that are already in an ACO, and they're using the computer. They like it. They're engaged in it. They may have people who have really gotten good at using it and are sharing that information. And still worried about HIPAA, but I think developing confidence that they can manage the security issues in that process. Productivity is still an issue, as I mentioned in the survey, but now we're focused on the quality metrics and how are they gathered, how are they accurately measured, and do I have to enter more data? What do I need to do to make that happen? And so the challenge for this group, I think, is to try to fully automate and select quality metrics that we can fully automate so that they don't have to enter it, but it's rapidly available to them so that they can manage their practice, manage their patients, and make sure that they're doing the things they need to do. So those are the 3 stages. I know I didn't answer a lot of questions today, but I hope I created a few in your head, and maybe after the session you'll come up and share with me what your experiences are and what ideas you have about what we can do to make it easier to get the physicians on board. So thank you.
Last but not least, I'd like to introduce Steve Robertson. He's a Senior VP at Hawaii Pacific Health. Thank you.
Thank you, Christine. Good morning, everybody.
Good morning.
You know, when Hawaii Pacific Health formed in 2001, our main charter, our main mission was to clinically integrate 4 hospitals, 3 physician groups, and more than 40 outpatient centers. So the goal was that if any patient of ours ends up in any one of our facilities or sees any one of our physicians, all that information would be there. And that we'd foster the ability for clinicians to work in partnership with each other so that we didn't allow information silos to occur. So we actually set on about a journey of 7 years to actually do this, and we achieved it. So by 2008, we had more than 30,000 patients using an online portal to get their lab results, to talk to their physicians. We had a common clinical record for more than 1,500 physicians supporting all the facilities. And life was good. We hit our mission. But that was 2008, and that's old news, and so what? So in 2008, we sat back and said, what else can we do? We've been spending a lot of time and effort focused on ourselves. What we really need to do, if we're really going to improve care and drive out costs, we really need to focus more on collaboration with community partnerships, especially with our community physicians. So we decided on two things. We had first continue to partner on technology, but we'd also foster or create a clinically integrated network with our community physicians. And that is what I want to talk about today. So, in terms of the shared clinical record, we achieved pretty good success, but we actually offered it to our community physicians as well with a heavy subsidize, where HPH subsidizes up to 80% of the EMR. And we started that effort, and today we have 216 community care providers actually running their private practice today. And about 60% of that is primary care. We also committed to doing health information exchange. And in the lower right corner is the Hawaii Health Information Exchange. We're a founding board member with HHIE, working in partnership with Christine. But we also continue to push the envelope in other areas as well. Epic Systems do a pretty good job of talking to Epic Systems, so we partnered with Queens and Kaiser to establish that through a program called Care Everywhere. We're also now part of the eHealth Exchange, which is the national framework to do health information exchange, and we're connected today with Social Security and soon to be live with the VA. And we're one of the first pioneers who really pushed the envelope working in partnership with the Department of Health to do syndromic surveillance along with immunization registries. And the results of this health information exchange has been pretty phenomenal. Over the last 12 months, we've had almost 11,000 HIE transactions between Hawaii Pacific Health and other entities. And even connected, as is Kaiser and Queens, to 177 mainland systems that do this through Epic. That's all I got. No, I'm kidding. So I was trying to meet the timeline here, but but again, so what? We've established all this technology to do great things, but what it really comes down to, for us to really make a difference, it's all about information. It's not about technology, it's about information. And to be able to really do this well, it's that partnership and really driving this to the next level. So in 2008, when we looked at the technology, when we looked at health information exchange, what we also realized was we needed to do a much better job in analytics. We needed to be able to really, really look at our data and be a lot more proactive in reaching out to our patients by doing chronic disease registries, by being able to actually staff full-time to do population outreach, to be able to get the analytics tools so that we can look at risk, look at our sickest patients, look at our high-cost patients, really meet the intent of what accountable care is really all about. Well, we started a lot of that before accountable care actually hit. So when it did, we felt we were in a pretty good position. And by making that investment has now put us in this next level, where we have formed a separate company called Hawaii Health Partners, where we will offer some of the successes that we've had internally to HPH to our primary care and specialist physicians that wish to join that network. So in partnership with HMSA, we developed a contract where we get the aligned incentives and investments in place to actually make this happen. The company has been formed in the summer with a dedicated board of directors. The majority of the board of directors are made up of physicians, and the majority of those physicians are private physicians. And the goal is that, and we're well on track to do this, to be operational to meet the terms of that contract beginning January 1st. So a true accountable care organization. I think I did it.
Thank you.
Thanks.
Okay, so we can count on Steve to help us get caught up on time. So we have about 15 minutes left, and I'm going to ask a couple of questions to the panel. So I'd like you to think about questions that you'd like to ask the panel collectively or anyone individually. And we'll head over to the audience in a couple of minutes. So one of the questions that I have, and Steve, you touched on it a little earlier, was we've been hearing a lot this morning about accountable care. So how, moving forward in all three of your initiatives, how do you measure accountable care? How do you measure quality, and what needs to happen to do that?
I know we're a shy lot, so. You know, when you look at what's happening with accountable care, especially as it applies to Hawaii, I first want to say that, you know, with the Prepaid Healthcare Act, it hasn't quite been quite the impact that I think a lot of the states have sort of had in place. But probably the most powerful impact that's been is just the awareness level. You know, this moved it up to the top of the charts on the national interest. But it also, you know, this sort of thinking has sort of led to some pretty good success stories through the state. So, for example, when Hawaii Pacific Health was looking at how we're really going to drive down costs and provide better care, we looked kind of closely at what happened on the Big Island with the Beacon project. So Beacon demonstrated some pretty clear savings, again, not necessarily through technology itself, but through information. They were able to look at cost and drive it down by, I think the number was something like $10,000 per patient, which is pretty significant for the patients that they focused on, specifically looking at home care, sort of a post-acute care, outreach. And for Hawaii Pacific Health, we looked at those models. And we're in the process of using exactly that same sort of approach. You don't need to overwhelm problems with technology. That usually just creates more problems. And this is coming from a CIO that absolutely knows the truth of that.
Thank you.
So at Kaiser, we've actually been an accountable care organization since our inception. So as one of the leaders and to the community of Hawaii, one of our areas we're bringing in partnerships. So we incorporated with DaVita Health Systems for dialysis on Maui, and Liberty was actually the one primary service provider there, and we've worked with them to bring them into the community to lower the dialysis service costs, and done that with the partnership. We're also partnering with our state hospitals to help with triage and rounding with our patients at Hilo Medical Center. So we've done through technology, given them access to our patient information so that they can do that. I think the challenge for us all, and we've done care outreach, we have population care registries, we couldn't achieve the PCMH level 3 without doing all those Medicare gaps and being the single Medicare star rating of 5 in the state. So a lot of it is on our quality and service initiatives and making an affordable product, and then outreaching to the Health Information Exchange, the Department of Health. As Steve alluded to, we've also done those partnerships with the Care Consortium on the mainland, the Mayo Clinic, to provide that partnership for the mission and welfare of improving people's lives.
Okay, thank you. Dr. Magnuson, do you have any comments related to that question?
Just from the perspective that, you know, accountable care is really about population management and a system of care, right? So making sure that we have primary care, specialty care, hospital, and long-term care integrated and functioning, working together with common goals and common objectives with respect to the results that we get and the costs that we create. That's the accountable care thought. And I think that it's a great thought. I think most physicians really engage in that concept and see the impact on their patients of a bad system. So I think we all agree that we need a better system. One of the challenges, though, is that in this state, there are just so many of us that are still in very small groups and independent in nature. And so I think there's a lot of tension in the physician community right now about how this is all going to play out and what's my role, what's going to happen with my practice. And so I think everyone has this concept that it's an important goal and it's an important direction to go to, but there's a lot of anxiety about what that's going to mean in the long run. And we'll have to see how it goes.
Thank you. I'll ask one more question, and then I'd like to encourage you to come up to the mic. We have an open mic here. We are recording this session, and so we encourage you to speak into the mic. So the next question I had is, this morning we heard a lot about public and private partnerships. The governor's office is leading the healthcare transformation planning for the state of Hawaii. So my question is, and we have two private sector stakeholders and we have the School of Medicine perspective. So what role does the state play, or do you see that the state should play moving forward to help you advance your efforts in healthcare transformation?
I'll start, Christine. I think they are the enablers to really support that initiative. I think it's not just about regulating and putting those pieces and talking points together and saying this is what we'll do, but it really is aligning the infrastructure and the funding for those supports. So as the federal grants run out, we need to position and do that public partnership between private and public to make sure that we have sustainability with the health information exchange. And then we will achieve the transformation I think that we're looking for. But it really does take our senators, legislatures, and actually the community as a whole to see that as an important thing, and that access to information actually does improve my health outcomes, not just for me as an individual, but as the community at large. And I think the state does have a lot of say in terms of enabling that and making sure that we regulate and mandate and do those things. I think the Department of Health, with having the medical state health examiner say that we'll incorporate the lab services through the HHIE. Those are subtle changes that we need to do to improve information throughout the system to improve our community at large.
Thank you.
From the education perspective, we really need to think about what our workforce will need to do or be able to do in the future. A lot of change is occurring. I was recently at a AAMC, which is the Association of American Medical Colleges meeting, national meeting, and they are revising the LCME guidelines, which are the guidelines we need to meet as a medical school to stay accredited. And they have already revised the ACGME guidelines, which are for our residency and fellowship training programs, to include specific requirements for training and integrating those trainees in the quality and process improvement activities within the health systems they're training. So those organizations that are identifying what we need to do to train the future workforce have identified the fact that we need to make sure that they're fully versed in the quality goals and the outcomes measures and the safety activities that all of you are worried about and involved in. So we're in the process of retooling to make sure that all of our students and residents get that training. Interestingly, it's not hard to train the students and residents on the electronic health record because they don't know anything else, and frankly, they just wonder why they can't get it on their phone. And so, I think that where there's retirement, there's hope. And so, I really think that, I'm not worried about the younger generation in embracing the electronic health record. In fact, I think that one of our biggest challenges is going to meet their expectations on how fast it goes and how well it performs for them and for their patients. So we're doing a little less training on that. They're all using the electronic health record in the systems that they're in. And they're becoming familiar with it. And we're really retooling to make sure they know the outcome and the purpose of using the electronic health record. It's not a tool, it's not a gadget, it's not a toy to look at while I'm supposed to be lecturing them on something else. It's really meant to get specific outcomes and specific system results, and that's what we now need to train them to do.
I think the governor's office actually has it right. Because for us to really succeed is that we need to partner together, private and public, to foster innovation, to recognize those pockets of excellence that do exist through the state and really capitalize on that. So what you see with the Healthcare Transformation Project is Beth Easting and others pulling us all together and having these sorts of conversations. Where we sit at the table, we identify the good ideas, and we figure out how to leverage what each other's doing so we learn to improve ourselves.
Thank you. Okay, we're going to move over to the yes, and please ask your question. Thank you.
John Howe, a primary care physician. I'm old enough to remember the day when I would get a consultation note that was well-crafted, wordsmithed, and I could look at that note and in about 30 to 45 seconds really have a tremendous amount of information transferred to my eyes and into my brain. So now, as a user of a certified electronic medical record, and I point and I click and I use templates, I generate 4-page progress notes that I can send to somebody, but I know it takes them more than 45 seconds to look through my note and get any meaningful information out of that. I do type the stuff that I do in caps, so at least they can look at the capital letters and figure out this might be from the doctor. My question is analytics the answer? Is that how we're going to take this information that now is in the computer, but doesn't really get transferred to another physician easily? Is analytics going to give me that well-crafted, wordsmithed note that will transfer that information into my brain? That's the question. Thank you.
Thank you.
The short answer is no. Actually, with an electronic health record comes great responsibility, right? The power of electrons shows up in any one of our computers. I guarantee you that you probably have a PC that's probably got 3 or 4 years of information and just gets bigger and bigger and bigger. There's no reason to clean out your closet. There's no reason to try to be more efficient, because having more information is good, right? But I know from a Hawaii Pacific Health point of view, we have system-wide efforts specifically to sort of address, note bloat, to put in the relevant information that's readily available. There are some technologies like natural language processing that can go through and pull out key points of information, but at the end of the day, it's all up to us, all up to our clinicians to find the most succinct way to put that information. But IT does play a role in how it presents that information.
Thank you. Okay, in the interest of time, we're going to move on to the next question. Dr. Withy.
Hi, Kelly Withy with the medical school. As a physician myself, and having done a lot of focus groups with physicians, I can say that while I fully believe in the promise of EHR and IT, we have not gotten there yet. All the promises we heard in the last decade about how it'll make us more efficient, we're not there. But what the physicians in Hawaii seem to want most is an inexpensive EHR that talks to all the rest. And I was wondering, when Steve Robertson said that they pay 80% of the Epic costs, how much is it, do you guys think, for a physician, even with that 80% subsidy, how much is it every year for a physician to have an EHR? Because 65% of our docs are in groups of 5 or less, and this is money, right out of the business.
Sorry to hog it, guys. But you're right, it is expensive. It's an added cost. It absolutely is, and it's a greater burden. It does impact patient flow, workflow. I think, so that is a hard question to answer. In terms of total cost, yeah, it's going to cost thousands of dollars, not just in terms of the raw IT costs, not just in terms of the network costs, not just in terms of everything associated with it. It's costly. And it's our hope, though, that with the reform in payments, reimbursement, and quality dollars, that it begins to offset some of that burden because of the improvements in quality that an electronic health record can really provide if we're using it appropriately.
Thank you. Thank you. Next question.
I'll make this real quick. I'm from the Big Island of Hawaii, and I'm not a professor. I'm not an academician, but I am a community advocate. I'd like to know, coming from rural underserved communities, what kinds of projects, activities, information that the health information technology and the use of this can be really giving to the people in rural underserved communities where the social determinants, at risk. These are the people that are really sick. They don't have access, they're poverty, and they don't have jobs. So I really would like to know, because I want to do a pilot project. I want to do a pilot project where they can understand all the things that you're talking about and how it can help improve and be more meaningful to them.
So I think from Kaiser Permanente's perspective, we actually solicited the innovations funding for the mobile van project on the Big Island so that we could go out and outreach and do mammography screenings, actually see and staff with a physician or nurse practitioner in that clinic. And through the use of the HealthConnect system, we were actually able to do that so that you could connect. We've also added a clinic in South Kona to increase our bandwidth and visibility in the community to get closer to the needs of the Native Hawaiian population. And we do actually serve about 20% of the total Native population, not just on the Big Island, as a whole of the state. So getting ourselves out to those rural communities and using that mobile van with the sophistication that we have with the infrastructure for the Health IT and KP HealthConnect, we were able to do that outreach more efficiently to the community and not just have our brick and mortars out there. So we'd happy to partner with you.
Yeah, I guess I would embed the IT piece into what Beth presented earlier today, that really the benefit to the rural communities might be in the patient-centered medical homes and maybe enabling those primary care physicians wherever they might be in Hawaii to be able to do what they need to do effectively where they are. The coordinated care networks and having people reach out to people in their homes and in their neighborhoods to make sure we're attending to the things that their neighborhood really needs attention to. All of this has to be connected through IT, and people need to have the health information on the patients that they're seeing wherever they may see them. So I think the real focus, I think, is on those strategies of organizing care, and then how can the computers and IT make sure they have the information they need for what they need to do. And so I think the answer to your question, I think, is more the global plan that was presented earlier today, and we would enable that in some way, shape, or form.
Thank you. We're going to take 2 more questions. Thank you.
I'm going to ask a deliberately slightly provocative question directed at Kaiser. Kaiser has this long history with, you said, behaving or is an accountable care organization, and also extensive health IT, which is very impressive. So the provocative question is, why isn't Kaiser insurance cheaper? Or why didn't you have a slide up here about how, we've got all these much better health outcomes? Thanks.
Sure. So, as you know, healthcare is quite expensive. And so I think what we try to do is an affordable product. It's not necessarily about being cheaper. It's about getting parity with the types of insurance that we're offering. And that's part of the Affordable Health Care Act. What the system does, and enables us to do that more effectively and deliver services more effectively, and making sure that when you are healthy and thriving, so that we do the campaigns in the community or working with our public schools to help them grow their renewable energy and food so that they can eat that. I think that's what we're trying to do. It's not going to be a one silver bullet that health IT is going to reduce the cost of care. It's going to happen over time, and that's what we've actually started to see, is that health transformation. I think, if anything, what we want to do is bring that, what is the minimum standard of basic necessity in terms of that health plan that we can cover? And part of the mission with Health KP Kaiser Permanente is to make sure that we do provide that quality service at an affordable rate. So it's not necessarily cheaper, obviously, but I think what we want to do is have a quality product and service to our members so that we can make sure that they're getting the best quality care.
Thank you. Last question. Thank you.
I'm going to make my long question really short. I tell my children not to put anything on text or their computer that they don't want their grandmother to see. And the EMRs that you're sharing with everybody sounds wonderful, but I don't know if I want my diagnosis of HIV or my diagnosis of mental illness to be sent out to everybody in the everybody in the Kaiser system, everybody in the Queen system. Because no matter how much we as healthcare providers think it's a great idea, it's not a good idea for me personally. So we've taken away the ability for me as a patient to go talk to my physician and tell them something confidentially, because now all of a sudden I'm having to put in an ICD code that connects that with that, and other billing people know about it. The receptionist, when I come in and greets me, checks my medications, so she knows about my HIV status. There's a lot of issues that we're letting go out into this cyberspace that patients may or may not want to have happen. So even though we think it's a great idea, I think we have to look at really what the patients are wanting, and is this really something that they want?
Yeah, thank you for asking that question. It's very important because we have to balance privacy and security with availability of the information. I think part of the solution is to make sure that, that technically we have systems that are difficult to hack, and that's one element of it. The other is to make sure that we have very strong policy and procedure around who has access to the information and under what circumstance. And currently what's being described is that it's kind of an event-driven process. So I'm an emergency physician. I don't get to access your information unless you present to me and ask for my help, and I have your permission to go into the system and query that. But we also need to look at levels of security with respect to particularly sensitive information, as you pointed out. So a lot of that work needs to be done, and that needs to be in the forefront, I think, in order to get buy-in from patients and from physicians, that we got a way to do this that is safe and doesn't put the patient at risk for information being shared where it shouldn't.
Great. Thank you. Okay, would you like to add anything?
Well, I can from the health information perspective. We actually have worked with our physician partners around that specific topic about blocking those. So HIV diagnosis and mental health parity in this region and the state and aligning to those diagnoses in particular are hidden. So that's how we've...
The medication lists aren't, and you can always figure that stuff out by looking at somebody's chart. And only certain things like telephone calls aren't, so I have to be really careful about what I put in a telephone call conversation versus what I put in my doctor's note versus what I put in.
Right.
So it's not secure,
It's not
even
a
though you
perfect
think it
system.
is.
Yes, it's not a perfect system, but you also want to make sure that when that ER physician's actually looking at their medication history, they have a complete history, so they make an appropriate diagnosis based upon that. So, you know, I think it's protection, but it's also making sure that that patient care is handled appropriately at that time. And so we really have done some thought-provoking conversations around how we're going to do that. And then in Hawaii, our physician partners actually are the people that decide whether the data goes out of the system or not. So we put protections in process as well as technology.
Great, thank you. Thank you for joining us and joining this session, and thank you to the panelists today. Please begin to head into the main ballroom for lunch and for the lunch plenary. Thank you.